Hello everyone, welcome back. Today we'll be discussing about IgG4 related diseases. So what exactly is this IgG4? IgG4 is basically immunoglobulin G4, okay, the subclass of G4. So IgG4 is basically a bispecific antibody, okay. So this is a bispecific antibodies with anti-inflammatory properties. Right, so this is a less common percentage of immunoglobulin amongst all the immunoglobulins that we know. But this is anti-inflammatory in nature and it is a bispecific antibody. So over the course of time, there were some disorders which could not be grouped under one particular class, but they had a strikingly common feature, and this strikingly common feature was evidence of fibrosis. Okay. And we never really found out what the exact cause for this fibrosis was. So there was a spectrum of disorders which are now being grouped together as a IgG4 or immunoglobulin G4 related disorders. So what were those disorders? The disorders are type 1 autoimmune pancreatitis, then Mikulicz disease. Mikulicz disease was basically characterized by an unexplained inflammation of predominantly the salivary glands, predominantly lacrimal glands. There is atrophy of the tongue. Then there was this condition called as retroperitoneal fibrosis, where these patients presented with kinking of the bilateral ureters with bilateral hydroureteronephrosis. Then Riedel's thyroiditis, right? So there was an unexplained enlargement of the thyroid gland, and this was often confused to be a malignancy, but when you do a biopsy, the only thing that was found was again fibrosis. Then primary sclerosing cholangitis. Primary sclerosing cholangitis was characterized by obliteration of the bile duct and presented with cholestatic jaundice. So these group of disorders which was observed over a period of time, they were all different disorders with different names. But now it has been found out that the hallmark feature of this spectrum of disorders has been fibrosis, and hence they have been grouped together under one spectrum or one umbrella term, which is called as IgG4 related diseases. Alright, clear? So what are those disorders? That is type 1 autoimmune pancreatitis, Mikulicz disease, retroperitoneal fibrosis, Riedel's thyroiditis, and primary sclerosing cholangitis. Right? So the hallmark feature of all of these diseases has been fibrosis. Clear? So what exactly is the pathogenesis of this IgG4 related disorder? So this is a relatively new disorder amongst all the autoimmune disorders, and what exactly is the pathogenesis? Let us look at that. So this is characterized by elevated IgG4. Okay, so the immunoglobulin G4 levels, if you test in the blood, this subclass of immunoglobulins, though it comprises of a very minority percentage amongst all immunoglobulins, this particular immunoglobulin has been elevated. Now, due to unknown causes, probably due to some environmental triggers and in genetically predisposed individuals, this IgG4 causes abnormal activation of myofibroblasts. Okay, so there is abnormal activation of myofibroblasts. Okay, myofibroblasts are a group of specialized cells which involved in the production of transforming growth factor beta. So two keywords that you have to remember is abnormal activation of myofibroblasts, which causes unchecked stimulation of transforming growth factor beta, and this is the one which is mainly responsible for fibrosis everywhere. So if you look at pathology, wound healing, you see that this transforming growth factor beta is involved in wound healing, right? So here there is unchecked and uncontrolled activation of transforming growth factor beta, which causes fibrosis everywhere else in the body where it should not be fibrous. Okay, fine. So this is the basic pathogenesis. Now let us look at the pathology, right? So in patients with IgG4 related disorders, they are predominantly going to present as what? They are predominantly going to present as tumefactive lesions. Okay, they are going to present as tumefactive lesions which basically mimic a malignancy. Okay, so they are going to present as tumefactive lesions all over the body, present or which may mimic a malignancy, right? So they may present as maybe an orbital tumor, they may present as tumefactive lesions So they may present as tumefactive lesions, which is characterized by probably growth similar to orbital tumors, or they may also mimic thyroid tumors, right? So this is how they present. So how will you diagnose this? You will take a biopsy and you send it for histopathology, and this is what we will find. So the characteristic feature of IgG4 related diseases, when you see 4 points you have to remember, right? So when you take a biopsy from these lesions, you see a lymphoplasmacytic infiltrate. Okay, fine. So there is a dense lymphoplasmacytic infiltrate within that particular tissue. Second, you find evidence of eosinophilia. You find evidence of eosinophilia. Then you find evidence of fibrosis. Can you see this fibrotic strands like this? And what is this specific form of fibrosis called? It is called as Storiform fibrosis. Okay, this is called as Storiform fibrosis. And if you see the vessels, you will find evidence of obliteration of the vessels, and this is called as obliterative Phlebitis. Obliterative Phlebitis. So always remember there are 4 characteristic histopathological findings which you can find in IgG4 related diseases. So this is lymphoplasmacytic infiltrate, dense lymphoplasmacytic infiltrate, storiform fibrosis, and obliterative Phlebitis with evidence of eosinophilia in the peripheral smear. You can find blood eosinophilia as well. Okay. So remember lymphoplasmacytic infiltrate, storiform fibrosis, and obliterative Phlebitis. Very, very important terms when you describe the histopathological sample from a patient with IgG4 related disease. Okay. And also you see that the plasma cells account for more than 40% of the total cells, or more than 10% of the cells per high power field have IgG4 positivity. So if you do an IgG4 staining on the sample, you find that more than 10 cells or more than 40% of the total plasma cells per high power field have IgG4 positivity. Okay. So whenever you suspect a patient having IgG4 related disease, you take the sample. Maybe it will be a lesion in the thyroid, a lesion in the pituitary, a lesion in the form of a retroperitoneal mass, or a lesion in the form of an orbital tumor. Put it under the microscope and you find this dense lymphoplasmacytic infiltrate with 40% or more than 10 cells per high power field having IgG4 positivity staining. Okay, fine. So this is about the pathology of IgG4 related diseases. Now let us look at the different various clinical manifestations. So IgG4 related disease is more common in males than in females, similar to spondyloarthropathies, and it is commonly seen in the age group of 40 to 70 years. So let us look at the manifestations one by one. So first is the presence of this autoimmune pancreatitis. And how is this going to present? Autoimmune pancreatitis is going to present in the form of a chronic pancreatitis with pain on and off, and predominantly because this is going to cause infiltration of the pancreas, enlargement of the pancreas. The head of the pancreas is going to go and press or obliterate the bile duct, and hence it causes obstructive jaundice. Okay, it causes obstructive jaundice, and very, very importantly, it may mimic a pancreatic malignancy. Okay, so it may mimic a pancreatic malignancy, and when you do a CCT of the abdomen, the name sign is called as the sausage pancreas. Okay, so you may have a sausage-like appearance of the pancreas. We'll be looking at the images a little later. Okay, so this is your type 1 autoimmune pancreatitis with obstructive jaundice and sausage pancreas. Then there can be salivary gland involvement. Because of infiltration into the salivary gland, you can have tumefactive lesions of the salivary gland. But when compared to Sjogren's syndrome, the salivary gland that is involved here is submandibular salivary gland. Okay, so there is submandibular salivary gland enlargement, and this is usually painless and symmetric. Okay, So there can be painless and symmetric submandibular salivary gland involvement. Then what are the orbital manifestations? It presents like an orbital pseudotumor. Orbital pseudotumor presents with proptosis, pain, and you may confuse it for an orbital malignancy. The retroperitoneum, it can cause retroperitoneal fibrosis. Okay, so if the retroperitoneum is fibrosed, then the ureters which pass through the retroperitoneum can get kinked, right? And hence you can have upstream dilatation and hydroureteronephrosis, most often a bilateral hydroureteronephrosis. So if there is bilateral HUN, always think of retroperitoneal fibrosis. Then in the central nervous system, right, you can have Pachymeningitis. You can have Pachymeningitis and a characteristic tumor-like lesion that you can find, which is lymphocytic hypophysitis. So if you just look at the chapters that we had dealt in endocrinology, in the pituitary gland, there was a pituitary tumor which is very similar to a pituitary adenoma. But this occurs very rapidly in a postpartum female. In a postpartum female, it presents predominantly with headache. It presents predominantly with headache because this pituitary tumor grows rapidly and it can compress on the stalk, resulting in stalk effect. Now, if there is a pituitary stalk effect, which hormone gets elevated? There will be elevated levels of prolactin. Okay, so that is in brief what is your lymphocytic hypophysitis, and you will be surprised to know that lymphocytic hypophysitis is also a variant of IgG4 related disease itself. Okay, so IgG4 related disease can cause lymphocytic hypophysitis. Then in the kidney, IgG4 can predominantly involve in the form of tubulointerstitial diseases and membranous nephropathy. Bile duct involvement can result in primary sclerosing cholangitis, resulting in obstructive jaundice, and it can involve the aorta, resulting in aortitis, and in the lung it mainly causes NSIP pattern of ILD. Interstitial lung disease can also be an association. Okay, fine. So this is about the various clinical features with which IgG4 can present, and always remember IgG4 mimics a malignancy. Okay, so type 1 autoimmune pancreatitis, bilateral submandibular gland involvement, orbital pseudotumor, retroperitoneal fibrosis, aortitis, ILDs, lymphocytic hypophysitis, all of these are the various clinical manifestations of IgG4 related disease, right? So how do you diagnose it? We have already seen the gold standard will be a histopathological examination, and within that you do an IgG4 stain. Okay, you see for IgG4 stain, and the plasma IgG4 to Ig ratio will also be elevated, right? So if you do a blood test, you see that the plasma IgG4 to Ig ratio is also elevated. So can you see here, these are some of the clinical images. There is bilateral submandibular gland involvement. Here you can see that there is some involvement of the thyroid gland as well. And this is your characteristic appearance, sausage pancreas in autoimmune pancreatitis type 1. Okay, fine. Okay, so finally let us look at the treatment. So the surprising thing about IgG4 related disease is it is going to be very responsive to steroids. So the moment you give steroids, the lesion begin to melt away. So steroids is the first and the most important line of management, right? So you give systemic steroids and you taper it maybe over 6 to 8 weeks. If there is failure of first line, then the second line management will be a Rituximab based therapy. Rituximab, which is anti-CD20, Rituximab based therapy is a second line management. Okay, so this is about IgG4 related diseases for you. Thank you.